Okay, good morning, everyone. Today I'll be presenting a case that brings to light an important clinical decision and management of advanced heart failure patients. My case presentation will be about a patient with advanced heart failure and severe mitral regurg. With that in mind, let's dive into the details to understand furtherly the clinical context and the options. So starting with my patient medical background, he's a 50-year-old male known to have idiopathic non-ischemic dilated cardiomyopathy with ejection fraction around 25%. He has also known to have functional severe mitral regurg. He was following with us in the heart failure clinic and regular follow-up, and he was able to manage his baseline daily activity with minimal limitations. His baseline pro-BNP was around 1500, and luckily at that time he has no recent heart failure admissions. He was maintained on the 4 pillars of guideline medical therapies in a good doses, and he was maintained euvolemic on 80 milligrams BID of Lasix. His ECG was normal sinus rhythm and narrow QRX complex, and there is no conduction abnormalities. It's worth to mention that patient he was compliant to his clinical visit as long as his medications, and he has a negative history of drug abuse. Moving to his disease course, unfortunately, his disease course was not as stable as we hoped, as the patient had a first admission of acute decompensated heart failure with symptoms, and his pro-BNP was elevated at the time. Fortunately, that admission was a very quick admission, responded very well to the IV Lasix, and we discharged him with further optimization of his oral diuretics. We saw him shortly after the discharge, and he back totally to his biochemical and clinical baseline. 2 months after the clinical visits, unfortunately, again, the patient presented to the ER with acute decompensated heart failure, and this time he was in cardiogenic shock with elevated renal profile, lactate, and his pro-BNP was reaching up to 8,000. At that time, patient required inotropic support, plus with IV Lasix, and he did not require any mechanical circulatory support. He responded very well over days, and we were able to wean him off the inotropic support. After weaning off the inotropes, we did for him a right heart cath, which showed normal right-sided filling pressures, and his PA pressure was a mean of 33. His wedge pressure was 25, and we noticed in his tracing large V wave, which indicates severe mitral regurg. His cardiac index was reduced at 1.7, and to assess his RV function through his hemodynamics, we calculate his pulmonary artery pulsatory index as 2.7, and his CVB to wedge was 0.2, and both values are consistent with good RV function. Here you can see his echoes, transphageal echo, which showed significant central mitral regurg with dilated annulus, and dilated LV as well, with LV in systolic dimension of 5.7, and his RV was mildly reduced with TAPSE of 16. To complete the patient workup, we did for him a cardiopulmonary exercise testing, and with VO2 max of 10, which was significantly reduced, suggesting limited exercise capacity, and his VCO2 slope was 38, which was significantly elevated, suggesting poor hemodynamics. Both numbers were reliable since his RER was more than 1. The patient now is symptomatic with increased renal function. He started not to tolerate his guideline-directed medical therapies due to significant symptomatic hypotension. And at the time, we know that the patient needs something more than medical therapy alone, which brings us to the question, should we proceed with advanced heart failure therapies, LVAD or transplant, or should we consider mitral clipping first to address the potential valvular contribution to his symptoms?